everyone for joining to another Northern Virginia Family Practice Town Hall. We are very excited today to have a special holiday edition with Dr. Amy Kotecha. So I hope everyone is doing well. We just a quick announcement, just so you know, if you weren't already aware, COVID has been around for a bit, and now in the last week to 10 days, we've also been seeing a big surge in the flu. So if you have not gotten a flu shot, please do so as soon as possible because it is out there and running rampant. Thanksgiving holiday really gave it a boost. So please be aware of that and just take precautions as needed. And you can always go to your local CVS or pharmacy or come to our office if you need to get a flu shot. We're happy to give it to you whenever you need. And also, if you are not aware by now, just again, I still have a few people going to our old office. Remember that we are now moved and are in Arlington at 2445 Army Navy Drive. Please don't go to our old office. It is the old Anderson Orthopedic Clinic. So if you know that building, that's where we are. And if you're not sure, you can just go to our website and that'll give you directions on how to get to us, right? And so as for tonight, very happy to introduce Dr. Amy Kotecha. She is a doctor that's been working in the Arlington area for quite some time. And she used to be my next door neighbor when I was working at my old practice in Boston. She's an excellent ophthalmologist and somebody we refer a lot of our patients to and really appreciate it. She's also given us a number of lectures at my old practice. And so I'm very happy to see her do it for us at this new practice. And so hopefully you'll enjoy her presentation as well as we always did in the past. Dr. Kotecha is from Princeton, New Jersey, and impressively went to a 6-year program, which included both her undergrad and medical degree, which is a very difficult type of program to get into and accelerates both undergrad and graduate school or medical school being completed in 6 years. So that's obviously very impressive, and graduated from the Drexel School of Medicine with her MD. And has been practicing ophthalmology since 1999 and practicing in the Boston area since 2008 at Capital Vision. And she is one of the few ophthalmologists that we refer to regularly and really appreciate her excellent care of our patients. So I'm excited to have her here and give you guys the information. So just so you know, we had a little bit of technical difficulties, which is why we're starting with the presentation already up rather than our other way, but hopefully this will work. But if we have any technical problems, please be patient. We'll try to get through them as best we can. So without any further ado, please take it away, Dr. Kotecha.
Well, thank you very much, first of all, for inviting me. It is truly an honor to be invited to this presentation, and a pleasure to have been working with you both at your old and your new practice. I'm glad you're back in Arlington. Anyways, I wasn't really sure exactly what this audience would want to hear or talk about, so I did create a simple presentation, but we can, dive into questions later if needed, on just some very common eye diseases that most of us.
If I may jump in real quick, because one thing I forgot is if anybody has any questions, please put them into the chat box. You'll see the chat box there, and we'll try to get to them at the end as best we can.
Perfect. So as I was saying, I started out with some common eye diseases, and we can dive in as deep or not as our audience would like us to. So I'm just going to go ahead and start. I am in Arlington, Virginia, across from the Virginia Square Metro. The first one I talk about is one that I hear about daily, and it's dry eyes. I feel like I've been hearing about this one much more since the start of the pandemic with the increased technology use. It's a very common condition due to reduced ocular tear film that causes the conjunctiva to become red and irritated. Common symptoms include burning, itching, redness of the eyes, blurry vision. It can be due to not enough tears being produced, poor quality tears, or possibly increased evaporation. Risk factors include poor environment, lack of humidity, hormonal conditions, smoking, lots of screen time, and also due to some systemic medications. Just a picture of our eyes, where the lacrimal gland is and where the tears are produced, in addition to where they're drained, which is down into the lacrimal system and then into the sinuses. And you can obviously see this little model has some red eyes from her dryness. Some of the medications that can cause dryness include allergy antihistamine type medications, hypertension medications, especially diuretics, some antiarrhythmic drugs, some anticholinergics. We also see this in people who wear contact lenses a lot, and patients with blepharitis, which is another condition I'll talk about later, as well as in autoimmune conditions such as Sjogren's syndrome. We see it with rheumatoid arthritis, infections like herpes simplex. It's also quite commonly seen, but not always, in some patients who've had a history of LASIK eye surgery, which we also do perform.
Amy, do you mind if I ask you real quick? So that for antihistamines, obviously Benadryl and the sedating antihistamines certainly cause it. Do you see it much with like Claritin or Zyrtec?
I do see it with those medications as well. However, I would say it is much more common in the first Benadryl, diphenhydramine type antihistamines than it is with the Zyrtec. Yeah. Treatment. We highly recommend lubricating drops. Lubricating drops, one of the favorite brands we have is Refresh. Other ones include Systane, Genteel. Please stay away from Visine type products. They often take the red out, but in the long run, they make things worse. And it is unfortunately one of the most common ones that that patients reach for, but doesn't really help the underlying dry eye syndrome. Using humidifiers at your workspace or in your bedroom can be helpful. Obviously, drinking more water. Taking fish oil or flaxseed oil supplements can improve the quality of the tear film, and also can be helpful in a natural way. And then, of course, we do offer many other treatments that we can do in the office. The diagram, I know it looks scary, but it's actually very tiny little plugs that can be inserted. They just take a minute to put in, that help maintain moisture in the eyes. We have some that dissolve in 2 weeks if you just want to try them out and see how they are. And then we have long-lasting ones. And then we do have, I'm kind of excited that we have a host of new medications that have come out recently. Restasis has been out for over 10 years and helps you make more tears and better quality tears. But there actually are 3 other competitor products, which are also really good for dry eyes. Many improve the signs and symptoms of dryness. And Tervea is actually a nose spray. So if you don't like putting drops in your eyes, we do have a few other options as well. If we don't have any other questions on dryness, I was going to move on to another very common condition that we see pretty much daily in my practice. I don't think it's recognized as well by patients though, and it's called blepharitis. It's a very common eye condition that has inflammation of the eyelids. It's characterized by crusty red eyelids. A lot of patients will complain that they wake up with like sleep on their eyes. It's very itchy. Some people think they have a conjunctivitis or something going on, but oftentimes it really is just blepharitis, which is caused by oily deposits on the eyelashes. It can cause pain, irritation, itching, redness, and watering of the eyes. And this is a picture of what it would look like if it's really bad and out of control. You can see quite a bit of crust or scurf by the eyelashes. You can see that the eyelid looks, it's obviously an exaggerated picture, but the eyelid looks very red and inflamed, particularly at the lid margin. What causes this? Some people are just more prone to it. Those who have rosacea are more prone to it. Certain ethnic backgrounds are more prone to it. It can be caused by staphylococcus on our skin, as well as Demodex mites, as well as just blockage of the sebaceous glands. Treatment. The initial treatment is actually very, very simple. Warm compresses, cleaning your eyelids with a clean, warm washcloth and baby shampoo used to be the traditional way of doing it. And it does work really well if you can remember to do that. However, these days we do have these over-the-counter products that can make life very simple and hygienic, and we have pictures of some of them on the bottom of the screen. OcuSoft wipes have antiseptic properties, and you just follow the direction on the packet, wipe with it. It's really great if you have an eye infection too, and you just toss them out. In more severe cases, we will prescribe topical antibiotics or sometimes topical antibiotic steroid combinations, which can really help calm things down. And then just we'll have the patients maintain with lid cleaning as needed. What happens when the blepharitis gets out of control? I'm sure many of us must have experienced this one. It's quite a nuisance, which people will commonly refer to as styes. In ophthalmology, we call them chalazion. And it's basically when that crust blocks the oil gland, and now you have this tender lump or infection. It can be external, it can be somewhat internal. Initial treatment for these would include warm compresses 3 to 4 times a day. And I do think if they are applied immediately from the onset of them, more than 80% of these will go away without any surgical intervention. We often do prescribe antibiotic and anti-inflammatory ointments, erythromycin or Tobradex, that can help speed this along and give patients some more comfort. And then if it is really being stubborn and not resolving, a simple surgical procedure in the office. We have an in-office procedure room, kind of like a dental chair that will lay back in a few minutes, and a microscope, and we'll take out the infection. You'd have a patch on overnight, but by the next day you'd be feeling much better. This just talks about the treatment that I just mentioned to you. So I'm going to move on to the next one. The next one is cataracts. I think most of us, as we get on later in life, it's nothing that we did wrong, but just with the natural aging process, the lens of the eye becomes cloudy and leads to decreased vision. Everybody grows them at different ages, but I would say most commonly we start to see the beginnings of them in our late 60s. Patients will come in usually saying, I think I need new glasses, when it might be that they really have cataracts. They'll also often complain of glare at night. They'll say the headlights coming on just seem so much brighter. Those LED lights seem much brighter than they ever remember them, and that's because the cataract is causing a scattering of the light. What we will see when the patients are in the office, obviously we can diagnose it with our slit lamp microscope, but also we see when we try our best to measure them with glasses, we just can't get them to 20/20 anymore. And when it is significantly reduced, then we talk about cataract surgery. Do understand that surgery can be a very scary process, but it's actually very simple and very successful. Most of our patients are very, very happy after cataract surgery. This is a picture of a moderate to advanced cataract. That pupil is dilated here in this image, but that yellowish, whitish color there is an image of what a cataract looks like, which when we're younger is pretty crystal clear.
I may say it's actually one of the coolest surgeries I've ever seen.
It is really cool, cataract surgery stuff. And the technology has become much better. And when I go to the meetings, I would probably say it's one of the fields that's definitely advancing yearly. So we do have laser-assisted options for cataract surgery. It's not all laser, but the laser probably does more than half the procedure, which will help soften up the lens, speed up recovery, and reduce the risk of complications. You can always be in the surgery center for a couple hours doing pre-testing and waiting afterwards, but the surgery itself usually takes about 30 to 60 minutes. All our cataract patients go home the same day for the most part. There's definitely some eye drops to use, like antibiotic drops, especially the first week, and then it tapers off. And most of our patients see improvement within, believe it or not, a day or two after the surgery. Really no pain. You're under anesthesia light for the procedure. And our patients get really excited about it these days because it's another way to reduce our need for glasses. We have different type of implants that will treat astigmatism. Different type of implants these days, we call them the bionic lenses is the nickname, but they'll also reduce your need for reading glasses. All right. I was told that you have quite a few maybe diabetics in the practice. So getting a diabetic eye exam, I can't stress enough the importance of having an exam at least once a year to screen for diabetic eye problems, and maybe sooner or more often if you've been found to have diabetic levels or if the A1Cs are really uncontrolled. Early stages of diabetic retinopathy are usually asymptomatic. However, when we take our photos or we dilate, we can usually see little blood spots or warning signs in the retina. Later stages can be quite severe and quite sad. They'll have symptoms of blurred vision, floaters, areas of missing vision. And when it gets really advanced, it's very hard to bring the vision back. We do have some pictures of what diabetic retinopathy looks like. They're coming up in a minute. The prevalence of diabetic retinopathy definitely increases the longer you've had the disease and the more uncontrolled the glucose and A1C levels are. It's due to these neovascular leaky vessels that grow when the glucose levels aren't controlled, and these vessels then leak in the retina, leading to bleeding, and left untreated can cause permanent damage and loss of vision. This is a picture of the back of the eye. We have special fundus cameras in our office. that even if you don't want to be dilated, although we definitely encourage dilation because we can see better and further out, but if you really can't be dilated, we'll still be able to get some decent photos of your eyes. The yellow circle is the optic nerve. The red squiggly lines are the blood vessels. And then if you look closer, you'll see these yellow spots and these red spots, and that's the leakage from the bleeding that the diabetic retinopathy is causing. The yellow is macular edema or swelling. And so if we were to see this, we actually do have treatments for this if it's affecting the vision. Sounds scary, but it's actually really not that bad. They're intraocular injections of medications that can dramatically improve vision, reduce bleeding. Of course, we still recommend that's done in conjunction with optimal diabetic control. And I do those in my procedure room in Arlington. And then this is a very severe case where can't even really see the proper anatomy of the eye anymore. There's just lots of bleeding and kind of scar, we call it fibrovascular tissue, and would be pretty certain that this patient of this image would have very, very poor vision. And this is proliferative because the blood vessels are leaking excessively here.
And if I can make a comment, if you don't mind.
Yeah.
Just also,
sorry, let me go back.
And certainly nobody wants to lose their vision. So it's obviously important to go every year, but also, you know, the eyes are the windows to the soul. It's also the windows to your health. And so if you have diabetic retinopathy, it means this is the only place in your body where you can directly see arteries and see problems with clogged arteries and whatnot. So if there's problems with diabetic retinopathy, that means there's problems elsewhere in your body as well, the kidneys, you know, maybe strokes, brain, other places that are having problems as well. So it's not only important to get it so you can maintain your vision, but it really is an important marker for your overall health, because obviously if there's diabetic retinopathy, even if your numbers don't look so bad, I'm probably going to treat you more aggressively for everything at that point. So it's also a good marker for the health of your entire body.
I think that's a really good point. You know, we do see most patients who have diabetic retinopathy usually have kidney problems too, they tell me. The other thing I would say is that, you know, people often ask, the good thing about eyes is you don't have to exercise them. You don't have to do too much with them. But I would say not smoking, taking good care of your blood pressure, taking good care of your cardiovascular health. All those things are really important because they will affect the blood vessels in your retina and they'll cause, I didn't get into these, but vein occlusions and the macular degeneration also more common, which we'll talk about next. Yeah. All right, macular degeneration. Another common condition that we see in our patients usually affects patients over the age of 60 or 65. It will result in a loss of central vision. Many of the patients that we have with macular degeneration will say when they look at lines like a grid or they look at their reading, things will appear wavy in the center. And that's what the macular degeneration will usually start off with. The two major kinds, one is referred to as dry and one's referred to as wet. Is a major cause of blindness in individuals over 60. There's definitely a hereditary component to it. So you're at higher risk if your parents or siblings have had it. Other risk factors, which you mentioned, include smoking, hypertension, actually is more common in the Caucasian population as well. Just a layman's image of what age-related macular degeneration might look like. Obviously, in the first picture, you can see these are like two cute smiling kids. But in the second picture, the central part is all blurred out. It's blurry on the sides too, but you know, very smudgy in the center. And that's what mac degen will do. Usually we'll take the central vision first. The picture that's shown here is a picture that we have these different types of testing machines in our office. They're quick, they're easy. This one is a scanning laser image, which is called an OCT or ocular coherence tomography. This one's actually a picture of a fairly normal appearing retina. But these images have been great advance in ophthalmology because they can help show us the diabetic changes. They can help show us the macular degeneration, a lot of things that sometimes are hard to see with just lenses, almost like a quick CT scan or MRI of the eye, but we do it right in the office and it only takes like a minute or so to do. We can do it without dilation as well. In dry macular degeneration, there are these drusen or buildup that forms between the layers of the retina and causes the vision loss. As I said, we dilate, we take fundus photos, and we take OCT images to help monitor progress. That's a picture of what dry macular degeneration would look like when we look in with our lenses on our or on our photos. We can see the optic nerve and the blood vessels, but all those yellow spots are what we call the drusen. The center of the eye is called the macula, and so that's where the vision is going to be affected. Now, about 10% of patients with dry macular degeneration will turn wet. Wet means that there's usually leaky blood vessels causing bleeding in the back of the retina. This is the type of macular degeneration that's very severe and will usually lead to advanced vision loss. The good news is we do have the same injectable treatments that we use for diabetic retinopathy, has also really changed the paradigm of treatment with macular degeneration. And if caught and treated early enough and regularly, we can help stop, in most cases, we do stop the progression from happening. And in many cases, we can improve it to some degree as well. There's also some new treatments out these days, which is for advanced dry macular degeneration, which is exciting because we never really had any treatments for dry mac degen other than vitamins. I'm sorry I didn't talk about that in the other slide, but vitamins like we call them AREDS vitamins, age-related eye disease vitamins, like Ocuvites that can be purchased over the counter without a prescription, can help slow down macular degeneration by about 25% over 5 years. So definitely something worth discussing with your ophthalmologist or primary care doctor. This is what mac degen can look like in the wet stages. You can obviously see this image has a big splotch of blood over there because the leaky vessels have leaked and have significantly damaged this patient's vision, unfortunately. This patient would be a candidate for those injectable treatments, though. I talked about that. Those treatments are what they're called anti-VEGF agents. And so they stop the growth factor that causes these bad leaky vessels to grow. They're often done monthly. However, we do have some new treatments that can be done every 2 to 4 months if needed, so you don't have to come in as often. However, we do still require regular follow-up and testing. We teach the patients how to test themselves at home as well. All right, we're getting towards the end, and then we'll take all your questions. Our last very common eye disease is glaucoma. A lot of patients get confused about what glaucoma is. Glaucoma is a disease of high eye pressures that damages the optic nerve of the eye and actually will start to cause almost like a tunneling type vision or loss of peripheral vision. The sad part about glaucoma is that it is painless, which is good, but many patients don't know that they have it if they're not going for regular checkups until it's too late. And a lot of the vision is already gone from glaucoma. Once the vision is gone from glaucoma and the nerve is damaged, we cannot bring that lost vision back. That's why it's important to have preventive eye exams so we can catch it and treat it early. The treatments are actually very effective and pretty non-invasive. Some risk factors include advancing age, positive family history. Does tend to be more common in African Americans. If you have had a significant trauma, like a blunt trauma to your eye, hit with a baseball, a punch, that definitely increases your risk for glaucoma. And steroid use, especially if used on the eye, but also any high doses of injectable or systemic steroid use can also increase risk for glaucoma. A similar image, the same two boys, but this is what glaucoma does. Glaucoma takes away the peripheral vision rather than the central vision, starting out. And if it progresses long enough, it can snuff out the central vision as well. There are two types of glaucoma, or two common types, I should say. There are many types, but there are two common types. Open angle is the most popular one. I would probably say 95% of the glaucoma that we see is open angle glaucoma. Again, I told you it causes loss of peripheral vision first. One of the ways we test it in the office is by doing visual field tests. Visual field tests are, you come into our office and you sit in this bowl type machine and you play, it's kind of like boring arcade game where the lights flash all around in the periphery and the center, and you press the button when you see the light. And then this gives us this lovely printouts. And to be honest, the patient, the first eye is what a normal one looks like. That's the normal blind spot. But the second one with all the dark areas is where the patient has lost that peripheral vision. And this patient should be on glaucoma treatment. We often start with eye drops that lower the pressure. They can be taken daily. I also have an SLT laser, which is a really quick, simple laser. It really takes about 5 minutes to do, that we do in the office. Many plans do cover it, and that can help lower the eye pressure. If the glaucoma is advanced, sometimes we'll need to use combination therapy. In rare cases, surgical intervention is needed. But to be honest, even patients who had that dark visual field without coming for testing, sometimes this wouldn't be caught. So that's why it is really important to see an ophthalmologist to get this checked. Tonometry, we check eye pressures in the office as well. We talk about visual fields. We also have that machine that I showed you, did the retinal scans. They also do really nice laser scans of the optic nerve and can help show us if there's damage occurring before it happens on the visual field image, before you actually lose the vision. Several different types of eye drops can be given. Most are 1 to 2 times a day. Many are generic options. And we talked about the laser surgery as well as more extreme surgery in advanced cases. The second type of glaucoma, this one's called narrow angle or closed angle glaucoma. It can take away vision very quickly and is considered one of the few ocular urgencies. If you ever read the package on some antihistamine type drugs and it will say, please don't take if you have glaucoma, they're referring to narrow angle glaucoma in those cases. If a patient has it, if they come in for routine exams, we can usually detect who's at risk by the shape of your eyes on the microscope. If you were to have narrow angle glaucoma or acute glaucoma, it's usually very sudden. Often one eye, painful red, blurred vision, and almost nausea and a headache that occurs up here. It's pretty acute. Some medications, believe it or not, dilating medications can cause it, like atropine. If you have it, please see an ophthalmologist or go to the ER immediately. To really ultimately treat it, a quick laser is done in the office. And once that's done, it's treated. It's just important to get that laser as soon as possible. I think that might end my slideshow presentation. There was a couple other things that I do. I can go back to any screens that I didn't talk about, but I actually do specialize in oculoplastics too. So any type of droopy eyelids, whether it be interfering in the vision or cosmetic, we treat those. Any minor skin cancers on the lids, so it's also important to come to get, like, people do get basal cells, sebaceous cells on the eyelids if you have any lumps and bumps that aren't going away. And then we do perform things like Botox and stuff as well, just for aesthetic reasons, as well as lid spasms. So I'm happy to answer any questions that anyone may have.
Great. Well, thank you very much. I think that was a very good overview of ocular problems and ophthalmology in general. I think you probably, this was just a good touch on there. So there's a lot more to talk about, I'm sure.
Oh, there is a lot for sure.
So, but I appreciate it.
We can always have another presentation on any specific topics
go
that
on
may
for hours, I'm sure. So, all right, and we do have a few questions, so I'll read these off and you can answer them as you can. So one person, Cecily Kidd, asks, can you have dry eye syndrome if your eyes are watery and teary when you wake up?
That's actually an excellent question, and the answer is most definitely yes. We get this question asked a lot by patients who come in and they have like the typical dry eye syndromes. My eyes are red and they burn and they're gritty, but it tears all the time, doctor. Tears all the time. I'm always drying it. How can you tell me I have dry eyes? Well, they do, because the problem is in that situation that the tears aren't the proper quality and they're not really staying on the surface of the eye. Tears are made of water or electrolytes, mucus, and lipids. And if it's not in the right balance and the surface gets dry or evaporates too quickly, then your body will try to compensate and it'll keep producing more and more tears to try to fix itself. And you get in this vicious cycle. And so you actually can tear too much and have dry eyes.
So that was fascinating.
Yeah.
And how common are secondary cataracts, and is the treatment any different than primary?
Okay, so I'd have to know exactly what the questioner is asking by secondary cataract. I think what they mean by secondary cataract is a cataract that occurs after the cataract surgery has already been done. And if that's what we're asking about, they are common. I would probably say in about 1 out of 4 cases, a secondary cataract forms. The term for this is a posterior capsule opacity. That's the medical term. Basically, I don't want to get too complex, but the cataract is that thick white lens, and it sits on a little membrane behind it. That membrane is kept intact during cataract surgery because it holds the implant in place and keeps the fluid in the back where it belongs. And it's on that membrane that a little film can form, like a little veil, It's not as bad as the original cataract in most cases, but it can make it appear smudgy or blurry after several months to a year goes on. The good news, it's one of my favorite things to treat. It literally takes 5 minutes. The quick laser that we also use for glaucoma has a cataract setting on it. And we just polish up the lens. It's called a YAG laser. Again, usually submitted. Is considered medically necessary. All we do is dilate, put some numbing drops in. We do one eye at a time if needed. And the patients, leave without it. It's painless. So very quickly and easily treated, but yes, they can happen.
And if you would mind, what about other secondary, such as due to steroid use or traumatic?
Okay, yes. So steroids can cause cataract progression. They often result in a very thick early type of cataract called a posterior subcapsular cataract. This is why we try to limit one of the reasons we try to limit the use of ocular steroids, even though they can make our eyes feel great. They can actually increase the risk of glaucoma as well. So our patients that we treat in the ophthalmology office, we follow closely on steroids for cataract and glaucoma progression and taper them as quickly as they can. Trauma would be another cause of secondary cataract progression. Sometimes radiation therapy can cause secondary cataract progression. Those are the most common ones I can think of off the top. Oh, diabetes. Diabetes will accelerate cataract progression too, especially if uncontrolled.
But that typically doesn't change your treatment. You would still be
no, we still do cataract surgery, but most patients don't want to get cataract surgery when they're very young. So,
yeah. And do concussions increase your risk for glaucoma?
Interesting. Concussions, no, but trauma directly to the eye, yes. Actually brings up another one of my specialties I didn't get into. I tend to take care of a lot of veterans in our practice as well. And many of them have experienced quite a few concussions and traumatic brain injuries. And while it doesn't increase cataract progression, it causes a whole host of other eye problems. The most common one I see is extreme light sensitivity or photophobia, very common after concussions. Another one, these would have to be severe concussions usually. But problems focusing, the eyes don't converge together due to trauma of the nerves. And so sometimes we have to do vision therapy type exercises or prisms. Those are some I could go on, but there are definitely several eye issues that can be seen post-concussions, but not cataract unless the eye was directly injured.
Oh, but it's glaucoma, the same, right?
Glaucoma is the same. Cataract, glaucoma, both. If the eye had a direct injury, and you know what, those things don't always happen. It's not going to happen within a week or two after the injury. It'll often happen years after the injury. So regular follow-up with an ophthalmologist if you have had serious eye trauma is very important.
And how important is heredity in macular degeneration?
Very much so. Yeah, very much so. I do think, it's hard for me to put percent on it, but I'll probably say 50% is due to your genetics. Another 50% maybe you can control by not smoking and diet and UV protection, etc.
You can't change your parents.
No, you can't change. I wish maybe someday. Change your genes, not your parents.
Someday, I'm probably getting pretty close.
Maybe.
One person asked, my mother had retinitis pigmentosa. Is this hereditary?
So retinitis pigmentosa is a very sad, rare hereditary condition. So it can be hereditary. Retinitis pigmentosa can lead to severe vision loss, usually night vision loss. They lose the vision in the periphery first. They have significant problems with night vision. The sad part about it is we don't have great treatments for it. There are some, we can offer supportive therapy. There's some vitamins and medications that can be tried, but nothing's going to make it go away. And yes, it can be hereditary. Not always, though. I would assume you could go to a geneticist. It can be X-linked, it can be dominant, it can be recessive, or sometimes it's just nobody in the family has it too, and it's idiopathic. So I do believe genetic studies could be done to determine what the mode of inheritance is. But if you have a family member with retinitis pigmentosa, I would highly recommend getting a dilated eye exam and getting it checked.
And then another good question. Can sinus pain and inflammation, I assume they were talking about sinusitis, can it cause blurry vision?
So I would say not directly, but indirectly. Obviously, anybody with sinusitis tends to have most people have pressure around like the ethmoid and sphenoid sinuses. And so a lot of pressure around the eyes will happen. The other thing I see with sinusitis is that because the sinuses are congested, our tear duct drains into the sinuses, most patients will have like more dryness in their eyes, maybe some blepharitis. And then obviously all these components are really important to proper vision and functioning. And so I think it can lead to some mild blurred vision.
And when we see it, a lot of sinusitis starts as a viral infection, which also can involve the eyes as well. So
Yeah, well, that's one we didn't talk about. We didn't talk about conjunctivitis. So yeah, I'll probably more likely get conjunctivitis. Conjunctivitis is, I know Dr. Lag see my red eye presentation, obviously very common. If viral or bacterial, will usually be acute redness and kind of like you wake up with sticky, gooey eyes in the morning. Can be treated with conservative teardrops, lid cleaning. But yeah, if it's not getting better, come see us because we can give antibiotic drops and or steroid drops if needed to help speed up the treatment.
And then next one is, without any specific problem except maybe age, how important are sunglasses, vitamins, or other regular eye care?
I personally think those things, I obviously am biased. I think those things are extremely important. Studies definitely do show, and I've done a volunteer mission in India where we did cataract surgery and things like that, where there is high exposure to UV rays. We see earlier cataract progression and higher incidences in earlier macular degeneration. So I think UV protection is the sunscreen for your eyes. Please don't put regular sunscreen in your eyes. That's going to burn. But wearing good quality UV protection, I think, is critical. The second we talked about before, like just taking care of your health, not smoking, controlling cholesterol levels, monitoring blood pressure and diet, and just keeping your blood vessels healthy and your heart healthy, I think will help with the eyes.
Do you know, do the AREDs or the vitamins that you talked about, do they have any role in prevention of macular degeneration?
So that's actually an excellent question. So the current vitamins that we use are the age-related eye disease 2 vitamins. It's based on the second study. And on that study, if you follow the study guidelines, it's really for people with moderate to advanced macular degeneration. And understand these studies go on for decades. So there is a preliminary result of a study for like people with family history of macular degeneration. And what those preliminary results are showing is that patients who take lower doses of similar vitamins, not the full dose in the AREDS vitamins, that it is proving to be useful in prevention. So if somebody wanted to take it for prevention, I would recommend one of two things. I wouldn't recommend the full dose, which if you take Ocuvites, one of these common brands, is 2 a day. You could take 1 a day if you wanted to. That's if your primary care approves of it. Or you could just do a multivitamin, maybe with some omega oil supplements. And I think that will give you a reasonable, supplement and a good diet. Obviously, a diet includes things with omega oils or salmon, colorful vegetables. We love colored peppers, kale, carrots. Yes, they are good for the eyes, those kind of things to help for prevention. So if you really wanted to do it, you could take 1 as prevention, but do understand the study's still ongoing.
So you're saying diet and exercise is good for your eyes.
Of course, exercise your body. The good news is you don't really need to exercise your eyes, although some people do. Like reading glasses, whether you exercise them or not, they're smooth muscles. You're going to need reading glasses. Really, for the eyes, I think we exercise them all the time on our technology use. That we tell patients the opposite. Sometimes they need to take breaks and stop staring at their devices for 5 minutes for every 30 minutes that you're looking at a device is a guideline. But exercise your body for sure.
Yep. And do floaters get worse with age?
Another good question. So first, let's talk about what floaters are. Floaters are pieces of pigment that are usually released by the retina, and they float around within the clear jelly of our eye. And most patients who have them, they are very common. Not everybody has them, but they're very common. When they look at a bright light or a white background, they'll see little spots. So often describe them as hairs or gnats moving across the vision, which can be quite bothersome for some. Do they get worse with age? Yes, floaters are more common as we age. The gelatin of our eye, the vitreous, becomes more liquefied, and the back of the eye starts to fray like a sweater, and little protein deposits will be released. So floaters are more common as we age. However, most patients with floaters, I'm not going to say all, do learn to get used to them. They often get better. Our body can absorb them and break them up. They can fall to the bottom of the eye. This process isn't an overnight process. It usually takes several months to happen. But and then I think we learned to tune them out too. So they do get worse with age, but most of the time doesn't require any intervention.
And this is one question for me is what I have my own personal recommendations, but what do you recommend as a routine visit for people, even if they have no problems? What age should they start getting routine screening,
Oh,
and how
wow.
often should they do that?
I told you I'm biased, right? I personally think even children should be screened. Now, what level of screening would depend, on the child. Hopefully, they're getting their vision checked at least at a pediatrician or the primary care office, and I think that can generate a referral. They should be screening in the schools at least yearly as well. Obviously, if you notice anything unusual, the eyes are crossing, they're staring too close to their device, or anything else, please take them to an ophthalmologist immediately. But I feel like those screenings need to be done. And if they're not done, that's where we see lazy eye developing, and then it's not treatable because we see that in people who come from other countries where they don't do these screenings. I think every adult should go to an ophthalmologist, either an optometrist, but my preference would be ophthalmologist, to get screened for eye diseases. If you come to us and I don't know, you're 20 something and we say everything looks healthy and you don't even need glasses, we might tell you don't come back for 2 to 3 years. Just call us if you need us. But I think getting a baseline test is really important, especially if you have a family history. And I don't think there's any age. I don't really want to see a newborn unless there's a problem. But if you can read the eye chart, I don't think there's any age that's too early.
I generally recommend people starting at about age 40 go every 2 or 3 years if they have no other symptoms or problems, just to make sure they're getting just a vision check, make sure their pressures are checked, because that's not something we can do in the office, and look at the back of the eye. So
I do.
if they have high blood pressure or obviously diabetes, certainly, then go to the office.
I mean, I think 40 is reasonable for an ophthalmologist, but I think even younger than that, optometrist, something, just go get checked.
And I'm curious, what is this test that you can do at home when you said they can go home?
Oh, well, obviously, we went through lockdown as well. So it's called an Amsler grid.
Yeah.
Do you know what Amsler grid is? I wish I had pulled one up. This is my laptop though. An Amsler grid is a very basic. It looks like your old geometry math grid with a black dot in the center. And what your patients do, and you can easily download one online, but we used to send them to people all the time during lockdown so they can check themselves. They're supposed to, if you wear corrective lenses, put them on. Take your hand, always cover one eye at a time when you check, because otherwise the other eye will compensate. And look at the lines in the grid and see if they appear wavy or straight. If there's waviness, if there's blurriness, if there's areas or holes in the vision missing that weren't there before, then that is a reason for an urgent ophthalmology referral. And so it's a great way for our MACD gens. They know what their baseline is and they check themselves daily. And it's a way to tell if it started to leak, bleed. It was really wonderful for when they couldn't come into the office for them to check themselves. I would do it virtually with them on the phone or on the videos, but it was a good way to at least self-monitor.
That's great. Yeah, that's terrific. Yeah. All right, well, good. I think that was all the questions we had. So that was great. That was a terrific talk, and appreciate all the questions and the great answers. Thank you, everybody, for joining us. Is there anything else you'd like to add? Or
Thank you. Thank you very much. And if there are more questions or topics you'd like to discuss, just let me know.
Great. All right. Well, thank you so much. Dr. Kotecha, you can find her in Ballston and at Capital Vision, right there. It was right there.
Yeah.
Capital Vision.
Small practice.
And I appreciate everybody attending. Thank you so much for giving us the talk, and I hope everybody has a terrific night.
Perfect. Thank you so much, Dr. Zweig. You have a lovely night and happy holidays to all of you.
Happy holidays to you, and happy holidays to everyone. Take care.
Thank you.
Bye-bye.
Bye-bye.